Hello dear all. Today's topic of discussion will be on constipation. This was a repeatedly requested topic, but I just kept on putting it off, and I think it's high time that we discuss this because this is a common problem that we see in our OPDs, and this is also important for your theory exams. So the way that I will be discussing I will be talking about what is constipation, what is the epidemiology that we see, what is normal and what is abnormal, and when you call it as constipation and when it is not constipation. This is very important for you to know. See, definition, yes, for theory that holds good, but when you are actually sitting in your practice, you should be able to differentiate constipation from other things. So you should know that. What is the pathophysiology of cause and consequence, clinical features, investigations, management and complications? Here I will be mainly talking about non-organic constipation and especially functional constipation among those. So definition wise, if you see, IAP 2018 has defined constipation like this. There are 4 D's in the definition. There is a delay in passage of stool with difficulty in defecation associated with distress for the child. Okay. So delay and difficulty in defecation resulting in distress. Anything less than 4 weeks is called as acute, and anything more than 4 weeks is called as chronic. This talks nothing about organic, inorganic, functional, non-functional, etc. This is just a definition of constipation. Okay. Note that they do not mention any frequency, they do not mention any, how to tell, there are no specifications is what I want to stress upon. It is just delay and difficulty in defecation resulting in distress. Okay. So that's about the definition. So what is normal? See, this is North American Society guidelines or normal frequency of bowel movements. So if you see there, in the first 6 months, if the baby is breastfed, average number of stools per week can be anywhere between 5 to 40. Whereas in formula fed infants, it can be anywhere between 5 to 30. And so on and so forth. And if you see, as the age advances, the frequency comes down. So in children over 3 years, average number of stool per week can be as low as 3, meaning once in 2 days also they can pass. Okay. This is North American data. What about Indian data? Yeah. So if you see Indian data, Indian society, less than 1 month, 3 to 4 per day. It can be even higher, okay, because as soon as the baby is fed, they pass stools. It's a reflex phenomenon, gastrocolic reflex. So you don't have to worry. 1 month to 1 year, 1.5 to 2 times a day. 1 to 2 years age group, it is 1 to 2 times. I think we can just put it as beyond neonatal period till 2 years, it is 1 to 2 times per day. And more than 2 years, it is once per day. Okay. Alright, so some anatomy and physiology before we actually go, and before that little bit about epidemiology. General OPD, 3% of cases that we see are constipation as pediatricians, but it is vastly underreported, and 3% is the patients those come with complaints of constipation. If you actually ask for every patient who is coming to you, you might find that many of them do have some amount of constipation, but they don't talk about it. In a GIT super specialist clinic, 20 to 30% of cases are belonging to constipation category. If you see, toddler and preschool is the most common age group for onset of constipation, and usually starts in the first year of life, and it is recognized later on. Females more than male are affected, and organic pathology constitutes only 10 to 15%, which means most of the constipation are functional. What about anatomy and physiology? Very simple. See, rectum continues as anus, and for the stools to pass, there are 2 blocks. One is the internal anal sphincter that I have mentioned in red, and in pink you see the external anal sphincter. And there is a gap of 2.5 centimeter between these two, and this is usually free of stools. Remember that point. The internal anal sphincter generally relaxes when the rectum distends. This is norm, okay. and external anal sphincter relaxes only if there is a voluntary signal. So what is the importance here? See, whenever stool gets accumulated here, blue stools are karde, okay. So whenever stools get accumulated here, the rectum distends, there is some pressure, isn't it so? Because of the distension, what happens is there is relaxation of anal sphincter. But the child will not be able to pass the stool till the external anal sphincter also relaxes. And the control is voluntary cortical control. Okay, this is very, very important. Imagine a child who is having constipation. When there is too much distension happening continuously, too much trigger initially might be there, but as the days goes on and on, the stimulation for internal sphincter reduces and no amount of distension will stimulate the internal sphincter. Okay. So basically it loses its sensitivity the more the rectum distends. Okay. And for effective passage of stool, you need this recto-anal angle, which is like this, to become straight. This becomes straight only if there is hip flexion. Okay. For normal defecation to happen, there should be straightening of recto-anal angle or anorectal angle, whichever way you want to call, and there should be a descent of pelvic floor. This happens effectively only if there is a hip flexion. Okay. So squatting is the best position because that is where hip flexes most, isn't it so? So when you squat is when you have the maximum hip flexion. So this results in a straight anorectum and easy descent of pelvic floor. So imagine a western potty that most of the houses currently have. If you see the angle formed here, I am sorry for the overwriting here, this should not happen. Yeah. So if you see the angle that is formed here, this is almost like a right angle, isn't it so, which we don't want. This anorectal angle is not the ideal position for defecation. But if you put a stool down, this lifts the leg up, resulting in reduction of this angle. Okay. And this reduction of up to 15 degrees can result in easier passage of stools. So this is the ideal position, and if the patient uses an Indian commode, that is the best mode. Okay. So this is about how the positioning is important while toilet training the child or while you are advising for a child with constipation. What leads to constipation? Okay. There are multiple contributing factors, predisposing factors, etc. See, there is a sudden change. If you see, whatever may be the cause, usually there is a sudden change because there should be some point of onset. Am I right? I am talking about functional. Remember that. If it is organic, it would have been there from the beginning. So a sudden change, as in say a change in the diet, a change in the physical environment that is present. Say the child is going to school, or the parents leave the child to work, leave the child with a nanny, or put the child in daycare, whatever may be. But there is a change and it causes an emotional distress, a stress environment. And if the child is started on toilet training early, then that results again in stress. Any minor illness, transition in diet, school environment, these are all common causes that will contribute to constipation. A little bit about toilet training. See, toilet training, ideal age to start is, it should be dependent on the child, is the right answer. Usually it is started after 2 years of age, not before that. And the child should be ready, as in the child should be able to indicate needs, that the child is able to able to tell you that the child wants to pass stools. Only then you can think about initiation of toilet training. It should be done by one person, one location, one word. Okay. So if the mother is the person who is going to sit with the child while the child is defecating, then it should always be the mother, preferably, and one location where the child is comfortable, calm, and not fearful of anything, and one word to indicate that the child needs to pass stools, and it should be consistent throughout. So if these are there, then toilet training becomes effective. But if the child is tried initiation too early, or if the child is reprimanded or embarrassed or made to feel embarrassed because the child has passed stool in the dress, soiled the dress, or whatever reason, then it goes for a toss and that leads to constipation. What is functional? Now I am talking about functional, isn't it so? So there is a Rome 4 criteria that defines functional constipation. So what is different from Rome 3? Rome 3 had this duration as 2 months. Okay, but this has reduced to 1 month. We will see what is the definition and then we will see why. So functional constipation is, you can remember this like a story. What will the patient come to you with? The patient is going to come to you with passage of painful or hard bowel movements, okay, or they can come to you with decreased frequency. They can come to you with fecal incontinence or excessive stool retention. And when you are examining the child, this child will have a large mass per rectum, and this child will also have a history of large diameter stools. Wait, I am not telling you a story, right? I am just reading out whatever is there. Yeah. So yeah, basically this child is going to have decreased frequency and large diameter stools, because of which it is going to be painful for the child, and because it is painful, this child is going to have excessive retention, and because of retention there will be fecal incontinence, and they will come to you, and once you examine there will be a large mass per abdomen. Yeah, now it is a story. Okay, so this reduction in timing from 2 months to 1 month is because they wanted early initiation of treatment. Okay, the earlier the treatment is initiated, the better the results are. Alright, that is why the duration was reduced from 2 months to 1 month. And the criteria that I just told is for infants to 4 years. What about older children and adolescents? Older children and adolescents, the same criteria with addition here of retentive posturing, and apart from this there should be nothing that fits the irritable bowel syndrome criteria. Okay, this is the criteria or definition of a functional constipation. So here what I should be teaching you is why fecal incontinence happens and why or what are the retentive posturings. Okay, right, we will talk about that in pathophysiology. I will just make a note so that I don't forget. So I need to talk about retentive posturing and incontinence, right. So this child is coming to you. First you need to know whether the stool is actually hard, soft, lumpy, what it is. For that you can use the Bristol stool chart. This is freely available online in multiple places. So it's free, available for download, and you can give this to the parents to have an idea of how the child is passing stools. There are 7 types. Okay, 3 and 4 is usually considered okay. Ideal is 4. Type 3, if the child is asymptomatic, you can put it under normal. Okay, first 2 are definitely hard stools, the child will find it difficult, and the last 3 are soft stools. Type 5 and type 6 is okay. Type 7 may be diarrhea. Alright, so what we need to know is type 3 and type 4 is what we are looking at. Type 5 is also good. Next, what are the types of constipation? Yeah, so now you know, now you have identified this child has a constipation. Next step for you is to determine whether the child is having an organic cause or it should be a non-organic cause. It's not inorganic, I am sorry. It should be whether it is a non-organic cause. So organic cause, as I said earlier, it constitutes less than 10%. And the younger the child, think organic cause. Remember it with the mnemonic MANS. M is for metabolic, A is anatomical problem, N is neuropathic problem, and S is a spinal cord problem. You can also add systemic disorders. Metabolic problem, hypothyroidism is the most common thing that you should be thinking about. calcium disturbances, increased as well as decreased calcium can cause constipation, hypokalemia due to ileus and uremia. Anatomical, any anorectal malformation, a stenosis, ectopic anus can cause constipation. Neuropathic, most important is Hirschsprung disease. IND is intestinal neuronal dysplasia. Okay, yeah. Next, S is spinal cord, spina bifida. You will look for symptoms in the back, signs in the back, tufted hair, pits, etc. S systemic disorders, I think it is self-explanatory. Non-organic constitutes nearly 80 to 90% of causes of constipation. What should make you think of an organic cause? History wise and examination wise, if there is a delayed passage of meconium, then it should keep you on high alert, especially for Hirschsprung disease. Early onset constipation, if there is a positive family history of not just Hirschsprung, it can be celiac disease or hypothyroidism. If there is a blood in stool, ribbon stool is characteristic of anorectal malformations. Fever, if there is a bilious vomiting, these are suggestive of an obstruction. Okay, mechanical obstruction. So, fever, yeah, appendicitis obviously, but yeah, think enterocolitis like that. Physical examination wise, any child who has who is not thriving along with constipation, be on extreme alert about celiac disease, that is often missed. So, failure to thrive, abdominal distension, abnormal reflex, abnormal position of anal or gluteal cleft, all of these reflex problems, spinal cord, you should be thinking about. Failure to thrive, as I said, systemic disorders you should be thinking about. Then extreme fear of anal exam. See, these children who have constipation, apart from what we discussed, the man's mnemonic, think of sexual abuse also. Okay, because no child is going to come and tell that he or she has been abused. Okay, so keep that also in the back of your mind. Don't look for it first, but don't miss looking for it when you are examining a child with constipation. This is what I want to stress, right? And again, signs of your spinal cord anomalies, abnormal thyroid gland, eczema. This red flag signs, I think you can find it in any of your standard textbooks. These red flag signs suggest an organic cause, which should make you more actively look for the cause and investigate the child, because per se functional constipation does not require an investigation. Clinical features, among the multiple criteria that you saw in your functional constipation definition, hard and dry painful stool is the most common presentation. Okay, and second most common is fecal impaction. What is striking here, at least for me, was, see, before I started learning all of this during my undergraduate days, I always thought constipation was lesser frequency. Never thought about the change in consistency. Okay, it was there, but I didn't think it was the first and foremost. So, if you see in clinical features, hardened and dry stool is given more importance compared to that of frequency. Okay, because if you just take frequency as a criteria to define constipation, 50% of cases will be missed. That's a huge number to miss, isn't it? So, where this is a disease in which early treatment will give a better response, you need to identify them early. Okay, so I will just give you two case scenarios. There is a case A where a 3-year-old child, both case A and B are 3-year-old. Okay, this 3-year-old child is coming with passage of stool once in 2 days. Okay, this child is coming with passage of stool once in 1 day. Okay, and this child has no symptoms, passes soft stools, and this child passes hard stools, strains. Which will you consider constipation? If you just take the frequency criteria, then you will be mistaken, right? So, this child will look as if he or she is passing daily, so there is no constipation, and here you will label the child as constipation despite the child having a soft stool. Okay. So, this child is actually normal because the child is asymptomatic, passing soft stools, that is probably normal for the child. Okay. Whereas this child is having incomplete emptying of bowels and this child is symptomatic. So, this child is having constipation. Okay. So, never ever just rely on your frequency. Okay. What is the pathophysiology? Pathophysiology, I think we already looked at factors, stress, parental factors. Apart from that, there are few genetic factors, colonic dysmotility. In fact, constipation is classified as slow transit, normal colonic transit, and how to tell? When the stool exits the anus, there is one term, I forgot. If I remember, I will definitely mention it. Yeah. So, the dysmotility disorders, impaired anorectal function, and diet, fluid intake we saw, any psychological disorders and behavioral disorders like autism and ADHD can have constipation. Okay. What does it lead to? So, there is a starting point somewhere which leads to the first painful bowel movement. Because of that, fearing the pain again, child has voluntary withholding. So, when there is withholding, there is fecal stasis. What happens? The rectum that is supposed to be like this, distance with stool matter, right? So, once it becomes too distended, it loses the ability to actually contract and expel the stool out. This becomes a hard mass. Okay. This becomes completely hard, and the newer stool that accumulates on top is still liquidy, right? So, what happens? It sort of percolates from the sides and the baby is unable to feel, okay, because the sensations are lost, and it soils the undergarment. Alright, this is the mechanism behind your incontinence or soiling. Retentive posturing is where this child is actually trying to withhold the stools. Okay. But the parents may try to or think that the child is actually trying to pass stools when they actually child is trying to withhold the stools. Okay. Retentive posturing can be just crossing of the legs. The child will try to do some sort of weird dance movements, and the child will look as if the child is training, but the child is not training to pass stool, it is actually trying to withhold. Okay. The body of the baby is trying to withhold the stools. So, retentive posturing, yeah, we talked about that. So, this is the pathophysiology, and this becomes a vicious cycle. Okay. Fecal stasis, there will be some amount of incontinence, and due to continuous stasis, whatever water is there will get absorbed, and the whatever is left out will become a hard mass, and when the child tries to pass again, it will be a painful bowel movement. So, this sort of spirals out of control where the child refuses to pass stool completely. Okay. So, how are you going to manage such a child? 4 P's. Okay. Parent education, patient education, plate modification and pharmacotherapy. All 4 are important. It is not just enough if you just give dietary advice and pharmacotherapy, which is what most of us do, to be very honest. Okay. That is not enough. Okay. That is just only 50% of the job done. If you want to do a complete job, you should definitely sit with the parent and the child and educate them as to what needs to be done. Okay. We will talk about each and everything a little bit in detail, because I think management of functional constipation itself can come as a long question. Oh, sorry. Alright. Just remembered I forgot to change the aspect ratio on this video as well. Let me see if I can do it later. Okay. Right. So, coming back to pharmacotherapy. Pharmacotherapy, there are multiple medications, but I am concentrating only on laxatives, and that too only osmotic laxatives, and that too only PEG, because that is the most effective medication that you have on hand. Okay. There are few papers on newer medications, and if I have time I will talk about that later, but not now. Okay. Yeah. So, diet alone, if you prescribe, it gives only a 25% success. Why is early initiation necessary? because early initiation will result in early benefit, okay, and all steps needs to be followed including disimpaction. Why? Because acute constipation goes on to become a chronic constipation, and this results in bigger and bigger sized rectum which loses its sensation, has abnormal motility. Only when you give such a long treatment for the chronic constipation, you can expect the child to actually become normal and without going back to the acute stage of constipation again. You need to break the cycle, okay. So, you need to give that long a treatment. So, treatment is not short, treatment is long, alright. So, duration of constipation and duration of treatment is usually almost directly proportional, and the treatment is usually in months, not in days, not in weeks, it is in months, okay. So, for pharmacotherapy there are two steps. One is disimpaction and the other one is maintenance. Both steps are necessary. Never ever miss the step of disimpaction, okay. Disimpaction, why do you have to do? You need to do that to keep the anal canal empty, okay. So, only if you keep the anal canal empty will the child not fear passing stools, because what is there in the anal canal is the one which is very hard. So, if you keep that empty, child will not have difficulty in passing stools, and direct maintenance treatment will actually cause paradoxical increase in soiling, abdominal pain and bloating. Hence, always start with disimpaction, not with maintenance. What are you going to give to the child? You are going to give polyethylene glycol, that is the first drug of choice, okay. And lactulose, if the child is less than 1 year, you can give. PEG, they use it off label, yeah, but usually less than 1 year lactulose can be given. Next, how are you going to give? There are oral route and rectal enemas. Oral route is always preferred, rectal route only if oral fails, okay, and rectal enema can be given. And role of stimulants in disimpaction is, disimpaction or maintenance is only very short, okay. Stimulant is used only if oral therapy fails, and that too only for 2 to 3 days to tide over the period of acute constipation and never continue it, alright. Coming back to disimpaction. So, now you have decided you are going to give polyethylene glycol, you have decided you are going to give orally. How long are you going to give and how much are you going to give, okay. How long is, for disimpaction it is just 3 to 6 days, and how much, it depends on age of the child. There are two methods where you can use. One is continuous incremental method, okay. This is UK guidelines, NICE guidelines, and the other one is pretty simple, this is Indian guidelines. So, Indian guidelines prefer a home based disimpaction if it is not very bad. If the child is having a very long standing constipation with huge fecal impaction, then do a hospital based disimpaction. You will give 1.5 to 2 gram per kg per day divided in 2 doses for 3 to 6 days. What are you going to give? See, this is something that all of you must have seen, right? I am not endorsing this brand or anything, to be very clear. This was a picture that was available to me and this looked clear enough. That is the reason. So, if you see here, 6.5 grams will be available with each sachet, okay. 6.5 gram of polyethylene glycol. This is what you are going to concentrate on. So, from 6.5 gram, you will be calculating with 1.5 to 2 grams per kg per day in divided doses. Hospital based, you can give continuous, make the child drink continuously or through nasogastric tube till the stool becomes watery, okay. This is hospital based. Home based, how do you know the stool has disimpacted? If there is a large stool passage and following which soft stool the child is passing, then disimpaction is successful, okay. So, this is your home based therapy, this is Indian guidelines. What about the UK guidelines? UK guidelines 1 to 5 years and 5 to 11 years they have divided. More than 12 will be similar to adult disimpaction. 1 to 5 years, day 1 and 2, 2 sachets, 3 and 4, 4 sachets, 5 and 6, 6 sachets. Basically, every second day you double the amount of sachets the child is taking till the child passes a large stool. Usually, rechecking or reassessment whether the child needs to continue the disimpaction regimen will happen at 4 days. Okay. 5 to 11 years, every day you can double the amount of sachet, and you start with 2 sachets in 1 to 5 year old child, and more than 5 years start with 4 sachets. Alright, I hope I am making sense to you guys. So, if you find this regimen very complicated, just stick to this. 1.5 to 2 gram per kg per day for 3 to 6 days in divided doses twice a day. So, how are you going to give? This is in a powder format, right? So, 1 scoop with 50 to 60 ml of water can be mixed and it can be given to the child. And 2 forms are available. This is again a common question that is asked. Should we give PEG with electrolytes or without electrolytes? PEG is polyethylene glycol. See, both are equally efficacious. There is no difference in efficacy. This is very, very important. You can use either of them. Okay. One point that you can remember is the one without electrolytes has a better palatability. Okay. Whereas the one with electrolytes, it's not that great, slightly salty. And large volume, whenever you are using, you can use it for disimpaction, and better palatability one you can use it for maintenance. But practically speaking, it does not make a difference. You can use either of them, and without electrolytes you can use because it has got a better palatability. How to give, we discussed. So, that is about your disimpaction. Once your disimpaction is successful, then give maintenance therapy. How long are you going to give? What are you going to give? You are again going to give polyethylene glycol. Okay. Polyethylene glycol will be given at half the dose. See, your disimpaction was 1.5 to 2 gram per kg per day, whereas maintenance is 0.5 to 1 gram per kg per day. Minimum age to start is 6 months. How long are you going to give? Again, how long depends on the child. Usually for 3 to 6 months at least it is given. Okay. Because why I am saying depends on the child is, see, you cannot follow a guideline and say after 3 months I am going to stop maintenance therapy, or after 6 months I am going to stop maintenance therapy. No, it cannot happen like that. The child has to be on a proper diet. This child should have had toilet training. This child should be comfortable. Isn't it so? Only when the child is ready you can start weaning off. And weaning off also should happen slowly over 3 months. When do you decide to start wean? You decide to start wean after the child has been symptom free for 6 months on your PEG or laxative. Clear? Alright. So, now you have given this and maintenance and you follow up the child. So, this is just a flow chart. You can also follow the one in Indian Pediatrics, that is also beautifully given. So, just to run through quickly. So, if the child is having symptoms of constipation, you do a history and physical examination to rule out organic causes, and once you find out it is a functional constipation, the 4 P's you will do. They have labeled it as dietary, education, behavioral intervention, and if there is fecal impaction you will do disimpaction, and if no, you go for maintenance therapy. See, most of the children with chronic constipation do have disimpaction. Fecal impaction, I am sorry. When do you call it as fecal impaction? Fecal impaction is when there is a hard mass in the lower abdomen, per abdomen. When you are doing a per rectal examination, dilated rectum filled with large stools. In X-ray, there can be stool accumulation, large distension of large bowel will be seen. Okay. So, yeah, maintenance therapy you will give, and if the treatment is effective, you will continue maintenance therapy. Watch out for relapse. This is very, very important. Most common cause of relapse is this child not taking the medication. The child is given reduced medication because parents fear it becomes addictive to the child, or the parents switch over to a different medication because they think this child is having reactions to the medication, because the child is passing too soft a stool and the parents are not used to it. they think that it is a loose stool rather than the normal soft stool. Okay, and see if the child requires a psychological evaluation, and always if the child relapses, think about fecal impaction, never miss that. Alright, if the child is not relapsing and doing well for 6 months, then wean and observe the child. If the child is having intractable constipation, then requires investigation for further management like manometry. They will look for colonic transit times, etc. But that is all super specialty level talk. So when do you call a treatment as effective? This you need to know. You have given treatment, I am right, but how do you know this child has actually responded to you? If the child is passing normal stool on laxatives after 4 weeks of initiation of treatment and normal stools for at least 6 months minimum, then you call the treatment as success. What is normal? Normal is something you can talk about only if there is a abnormal, isn't it? So there is no definition for normal, right? So what is normal? If the child is passing daily stool, if the child is passing non-hard, non-watery stool, there is no pain, no strain, no bleed, no posturing and no incontinence. If all of these are there, then you call it as a normal stooling pattern for the child. Okay, then you call the treatment as success. And if the child has maintained for 6 months, then you wean slowly over 3 months. Some practical questions and answers that I thought I will jot down here. What to do if there is cramping or bloating? See, cramping or bloating is more common with lactulose or lactitol like laxatives compared to PEG. So switch over to PEG if the child is already on these, and always rule out fecal impaction whenever there is bloating. Next is banana and constipation. This is a very common question that gets asked. Doctor, the patient is having constipation, my child is having constipation, I am giving her or him bananas, but still it is not improving. Remember, only unripe banana has more fiber content, not the ripe ones. Okay, the pectin content in it reduces as the banana ripens. 3.1 gram fiber will be there in a medium sized banana in an unripe banana. That is very important. Ripe bananas do not do much except that it tastes better. Alright. So there are other fruits which are better for constipation in terms of fiber content, like chiku, apple, guava. Those are all good in fibers. Alright. So constipation in a baby who is less than 6 months. If first of all confirm it is actually constipation and there is no organic cause. If none of them are there, then you can give a enema, okay, glycerin or saline enema and lower dose than usual. Alright. Preterm baby with calcium supplement with poor gut motility, this is a common scenario for people who are managing many preterms. Then again enema can be tried. Enema is usually a glycerin enema or a saline enema. There is no recommendation for use of probiotic or prebiotic as of now. So this is about the pharmacotherapy. Next, coming to the parent, patient and plate. See, parents, you should teach them about the role of withholding behavior. Tell them the child is trying to retain or not pass stools. Explain why constipation happens in the first place. And tell them the concept of overflow incontinence. Don't make them think that it is diarrhea. Okay. Next, structured toilet training. Make sure the child is ready, the child is passing soft stool. Only after then start a toilet training. Okay, that is very, very important. Only after the child is passing soft stool, start toilet training. And make use of the natural gastrocolic reflex. There are two components to it. There is a early 10 to 15 minute gastrocolic reflex and late 30 to 40 minutes. So make the child sit in potty after say 30 minutes, a meal. Okay. So the child will be sitting in the potty 2 to 3 times per day. If the child passes or not passes is a different scenario. But make the child sit. Let the child get used to the feeling. And address child rearing attitudes. Tell them there should be no stress, both emotional, physical, and avoid embarrassment or punishment if the child is soiling or not passing stool. Behavioral therapy is more helpful in adolescents and older children, and biofeedback. physiotherapy for pelvic floor exercises. All of these are more for older kids who can understand what we are trying to tell. And stress on the importance of prolonged therapy. This should be talked of in the first sitting itself. When the patient comes to you for the first time and you diagnose a constipation and you start treatment, tell them it is going to be a long drawn process. It's not a 1 or 2 day job. Okay, they require regular follow up, and usually first follow up will be by 4 weeks post initiation, because you need to know if the child's stool has normalized. That was one of the criteria for you to tell the treatment success, right? Okay. Next, plate wise normal fiber, normal fluid. There is no need for increased fiber. This is again an important point. Recommendation is only 0.5 gram per kg per day for children aged more than 5 years. Okay. There is no role for increased amount of fibers or increased amount of fluids. Fibers wise, in fruits, if you see apple, chapota is chiku, orange, guava and pomegranate have increased fiber content, and vegetables wise, beans, peas, cabbage, cauliflower, those have increased amount of fiber content. Avoid maida. Maida is usually there in bakery products, biscuits, your suji. Yeah. Avoid milk containing products. Avoid banana and papaya. All right. What are the masqueraders of functional constipation? This is just out of interest. Masqueraders of functional constipation are false. Masquerade is false, right? So F is food allergy, A is absent thyroid, L is lead poisoning, S is spinal cord, E is a enteric problem. It can be like a celiac functional disturbance, I can call, no, pathology, but okay, let's just put it as celiac disease and Hirschsprung disease. All right. So now you have treated the child. How many children you treat do you expect to get better? 50% resolved by 1 year of age, not age, 1 year after you start treatment, and 70% resolved by 2 years. 30% can persist into adolescence, and 30% can have resistant intractable form, and those need workup further by a GI super specialist. Okay. I think this is more than enough for you to write your exams and manage your patients. Thank you guys for your patient listening. Sorry in advance if this also turns out to be in a skewed aspect ratio. Forget my sorry if the aspect ratio turns out to be fine and I am able to do something about it. Bye bye, take care.